All right, well, I think we'll go ahead and get started. It is about 1:02, and if people join later, we will welcome them in. Thank you so much for joining on a Friday afternoon, especially a Friday the 13th. My name is Lindsay Green. I am with Coordinated Care's Apple Health Core Connections program. Coordinated Care is one of the 5 Medicaid managed care plans here in Washington. And we are the Medicaid plan for children and youth who are in foster care, adoption support, alumni of foster care, and also for families who have reunified 1 year post-reunification. And we serve those members through our Apple Health Core Connections program. So we'll talk a little bit more about kind of what coordinated care is and what we're able to offer. I think my colleague Zia has been doing some trainings for CASA staff and CASA volunteers across the state through Ryan. So you might be familiar with this logo in my background or on the screen as well. And I'm basically the Zia of Western Washington. So I'm based out of Snohomish County and serving the western part of the state. So happy to be here with you today. I know it's a Friday afternoon, it's 1 o'clock. I really encourage everybody to take care of yourself today during today's training. We're going to be talking about how to help youth access behavioral health services. And if we want to hope to retain any of this information, we also have to be taking care of ourselves. So if you need to get up and stretch or take a walk or go get some food or do whatever, I have absolutely no problem with that. I have gone ahead and muted everyone. But you can feel free to take yourself off of mute if you have any questions that you'd like to ask, or feel free to use the chat box to ask questions. Either way is completely fine. You probably saw a notice that Ryan is recording today's training, and that's for people who were unable to join to be able to watch at a later time as well. But please still feel free to come off mute or to type in the chat box if you've got any questions as we go through today's content. Trying to think, we are going to send out via email the slide deck and some other resources and materials for you as well. So know that you will be getting a copy of the slide deck. And if I remember at the end, you can remind me. I will also go ahead and drop the slides in the chat box as well for you. So with that, let's go ahead and get started. Oh, the other thing I was just going to say, in general, it's been taking about an hour and a half to get through this content. So my guess is we will be done a little bit before 3 today as well. So just a little forward looking for us there. Okay. So here at Coordinated Care, we like to start every meeting and training with a land acknowledgement. Because we are all joining from different places of the state, you'll recognize that this one, or you'll notice that this one is rather broad, right? But we acknowledge that we are meeting on the ancestral lands of Indigenous peoples. We honor the connection American Indian and Alaska Native youth have to their lands, recognizing its importance in healing historical trauma. Okay. So a little bit more about coordinated care. I'm thinking many of you are probably familiar with this. But just to be sure, we wanted to do a quick reminder about, what is coordinated care, right? So coordinated care is one of the Medicaid plans here in Washington. If you work in a county that does not have coordinated care for, general Medicaid, we are still in your county for children and youth who are in foster care. So the Apple Health Core Connections program is absolutely statewide. And we have about 25,000 members through Apple Health Core Connections that covers children and youth who are in an out-of-home placement, children and youth who are in adoption support. So when families finalize the adoption through that adoption support agreement with the state, they can work to get Medicaid ongoing for their child once the adoption is finalized. Some families, may choose to enroll the child in their private medical insurance. If that's the case, then the child would still have Medicaid as secondary coverage. But if they have Medicaid as their primary insurance, then they can stay with the Apple Health Core Connections program while they're in adoption support. And then also for members who are in foster care on their 18th birthday, regardless of whether or not they choose to participate in the state's extended foster care program, because of the Affordable Care Act, they are covered by Medicaid through the month of their 26th birthday. So that's a really wonderful benefit and resource that we sometimes find our youth are not aware of. but they absolutely have Medicaid through the month of their 26th birthday. They don't have to take, any action. They don't have to fill out any enrollment paperwork, anything like that. They are just automatically eligible for Medicaid till that time. And then children and youth who are reunified with their parents can remain with coordinated care 1 year post-dependency. So that the youth is still with coordinated care during the child return home period. And then they have the option, if the family chooses, to keep the child in the Apple Health Core Connections program for 1 year post-dependency, as long as the parent or guardian meets the income requirements or resource requirements for Medicaid. So a few exceptions to enrollment. If you have any Native youth who are on your caseload, Native youth or Native people in Washington State are not automatically enrolled in managed care plans. And so that's also true for youth who are in foster care that are Native. So those youth can choose to enroll in our program, but they are not automatically enrolled in Apple Health Core Connections the way that, that other youth who are coming into foster care are. Another exception that I would just highlight real briefly too, for those of you who have maybe older youth on your caseload, if that youth does go into a JRA facility, they're still receiving medical coverage while they're in JRA. It's just not through us, but there should never be any gap or lapse in Medicaid coverage. So as soon as they are released, they are eligible for Medicaid with us again. So that's just a little bit of a landscape around Medicaid here in Washington. Yeah, there was a question in the chat. The last slide in this PowerPoint deck will have my contact information on it, and you'll be receiving the slide deck, and I can also put it in the chat in just a moment too. And so if you ever are having a hard time with a child on your caseload where you're trying to access physical and behavioral health services for them and things just, don't seem to be working the way the system is supposed to, which is everything we're going to talk about today, right? How the system's supposed to work, how to help navigate that system. You can reach out to me, or I will also give you some other contact information that'll be really helpful throughout the presentation today. Okay. So we have kind of 5 main learning objectives today. First, if we're going to be talking about behavioral health care, we really want to make sure that we have a common trauma-informed framework, and really that, all systems and providers who are working with youth are coming from this work from a recovery-oriented, strengths-based perspective. So we're going to talk a little bit about that. And then the bulk of our time is really going to be on objectives 2 and 3. So that's kind of our meat and potatoes today. Understanding and navigating the physical and behavioral healthcare systems, and understanding the requirements to access services based on medical necessity. So that's what we're going to do, really the deeper dive today. And then lastly, just looking at some terms that are commonly used differently by child welfare and healthcare systems to kind of help bridge that divide. And then identifying Medicaid and non-Medicaid services. I will say I've done this presentation a couple of times with some attorneys and other court systems at this point, and everybody says this presentation would be so great for DCYF caseworkers. And that's actually originally kind of one of the main audiences that this presentation was intended for. So know that we are collaborating with DCYF to also share this information with caseworkers, but we also think there's value in having other professionals really have this knowledge too. And so if you can think of any other groups or places that might like this information, you can also feel free to reach out to me about that as well. Okay, so diving in, right, trauma-informed styles of communication and thinking are recovery-oriented, strengths-based, and person-centered. So we're going to give just a little bit more information on each of those 3. So recovery-oriented, this framework really came from the substance use treatment world. They're the ones who really developed this language, saying that recovery is possible for absolutely everybody. So recovery is different than cure, but recovery rather is finding stability and a place of kind of wellness around one's chronic condition. So that can be around a chronic physical health condition, like say maybe diabetes, where there's no cure, but treatments that can help people reach a state of recovery and stability, as well as for behavioral health diagnoses. So both mental health as well as substance use disorders as well, right? Not necessarily a treatment or a cure, but we can help people with the right treatment to get to a place of stability where they can, achieve their goals that they're setting for themselves. So that's really how we want to view things. I think of this in the child welfare world. I was a caseworker for quite a while, both in Virginia and here in Washington. And, sometimes you hear statements like, that youth is a lost cause, right? They're too far down the road, right? Or, there's no hope for that parent, right? Sometimes we hear language like that. That is not recovery oriented. That's really what we want to shift away from and really see the potential in each individual. So respectful, non-judgmental, clear and understandable, free of jargon, and carrying a sense of commitment, hope, and presenting the potential for opportunity would all be examples of recovery-oriented language. And just on that, I think we're all feeling really fatigued and, burned out given our current COVID-19 pandemic and just everything else that's going on in the world. And so, I think a lot of us are feeling this increase in cynicism in our workplaces, right? And some increase in, some unhelpful language. So just a good reminder to just pause and think critically when you're hearing these kinds of comments come up in your work and in the cases that you're working on. So some suggestions for words or phrases that promote recovery. This can be really helpful when you're writing reports to the court, right? Trying to talk about, people experiencing paranoia or youth who are experiencing delusional thoughts as opposed to calling the youth delusional or paranoid. So I think some of this probably looks familiar to many of you, and probably many of you are already doing this. But again, we just feel it's so important to offer, a reminder as we are talking about accessing the behavioral health care system, how these systems should really be talking about youth and families that they're serving. So the strengths-based perspective came from the field of social work and really took off in the 90s. And what it said is, so often we focus on all of the problems that a family or individual has or a community has. And we should talk about the strengths and the resilience and the capabilities of families, of individuals and communities with the same ferocity that we're going to talk about those problems, right? So really shifting away from a problem-focused approach to thinking about strengths, because that's really the door towards recovery and towards, finding some healing. Okay, so you can see here, little word cloud on strengths-based language to see some examples of that. To give you an example, right, the way we phrase things and talk about things really matters too, right? If you read, this young man is oppositional, defiant, severely aggressive, antisocial, only likes one staff, has anger management issues, right? Whoa, that seems like a really, dark place. It doesn't really seem like there's a whole lot of hope there, right? How are we going to get this youth to a place of stability and, wellness, right? But then you see the option on the left here, right? So the minor has been severely impacted by trauma and is showing PTSD symptoms, such as increased arousal, hyperreactiveness, mistrust, maybe fleeing behaviors, having difficulties in mood control, and observed by being easily irritated and angered, right? So from there, we have this perspective of, oh, the problem is this youth really needs some treatment for his PTSD symptoms, right? We can work with that. We can really offer some support and some suggestions there. So a real life example of this that happened, my colleague Heather shares this story. She was working on placing a young child in foster care, and he had been removed from a previous placement, and so the placement paperwork said that he had harmed animals. So this child was having a really hard time getting a placement because all of these foster families that had animals were saying, nope, sorry, can't take this child. Well, it turns out what had happened was the child had grown up in a home where there were no pets. He'd never had any exposure to animals before, and was in a foster home that had both a hamster and a pet fish. And those two enclosures were very near each other. And the child was young and creative and, full of energy, and thought, how fun would it be if the hamster got to swim and if the fish got to run on the hamster wheel? So he slapped the animals into those different enclosures, and both pets, died. And so, it got marked in the file as, this child has harmed animals, right? But what really needed to be in the file was this child is really interested and eager in learning about pets and needs a lot of support because he doesn't understand, many of the basics around how to care for animals, right? So we can see that, the way things get phrased in systems and paperwork sometimes really do have a huge impact on the lives of children that we serve. So just a good reminder to always be on the lookout for those kinds of things, and try to dig a little deeper or probe a little deeper if it doesn't quite make sense, or you feel like there might be a little bit, kind of more to the story. And then again, person-centered language. The main idea here is to, not talk about people as a disability, but rather recognizing, their diagnosis is a piece of who they are, right? It's not their entire identity. It is a portion of their identity. So instead of calling somebody an alcoholic, right, a person with a substance use disorder, or instead of calling somebody a schizophrenic, right, a person with schizophrenia. So again, as you're talking about families and reviewing court reports and writing them yourself, really good practice to be on the lookout for person-centered language, and you can help have an impact on families and systems by really promoting this type of language. Okay, so that was our quick little, 10-minute or so aside into using recovery-centered frameworks. And if you have any questions or want to talk deeper about that, I am more than happy to do so. And in fact, we'll just pause here in case there are any questions or comments on that first section. Okay, I'm not seeing anything, and that is totally fine. But again, feel free to stop me as we go through today's training. I'm happy to take questions off mute or in the chat. And while I was not talking, I was able to type in my email address in the chat box for you all to have too. But again, you'll get it in the slide decks as well. Okay, so moving on to our second kind of topic here, understanding and navigating physical and behavioral healthcare systems. All right. So want to start by talking about, we want youth and all youth, not just those who are in foster care, right? All people to be in the least restrictive setting possible, right? So maintaining a true state of health and recovery requires that a person be in their community. So all services, interventions, and resources are meant to move a person towards a state of health and recovery and to help them maintain that state while they are at home in their community. So levels of care above prevention are not meant to be permanent. Levels of care above prevention are really designed to, get that person back to that state of wellness. So recovery is the goal, and that means long-term stability, and recovery absolutely looks different for everyone, right? So let's see how that kind of, well, first we're going to talk a little bit. One of the things that came up when we were developing this curriculum and this content is that, all these systems that we work with, DCYF, Healthcare Authority, coordinated care, we all recognize that there is a huge missing level of care, right? So CLIP, or Children's Long-Term Inpatient, is a long-term treatment course. It's not a placement, right? DCYF is talking about placement needs in the sense of like, where is the child going to sleep each night? But CLIP is really not designed to be a placement, right? CLIP is a treatment that can be utilized to get that person back on that road towards recovery, to be able to be back in their community. And the other thing we hear a lot of times is, oh, coordinated care, can't you recommend that this youth go to CLIP, right? Can't you see how many needs they've had, how much they're utilizing behavioral health systems and the ER, right? We can't make that determination. Only a medical provider can determine if a youth requires treatment in a hospital. So where we see this huge missing level of care is for youth with intensive behavioral health needs, but they do not meet medical necessity for inpatient treatment. And so those youth often times have a really hard time with being placed, right? It can be really difficult to can be really difficult to find placements that are able to manage those behaviors. So DCYF, Healthcare Authority, Coordinated Care, we all recognize that for those youth, there is a huge missing level of care in our behavioral health continuum in this state. And so you are probably seeing that too. And I think it's something, you know, we're continually working towards finding answers on and trying to figure out how to better make the system work. But hopefully today you at least feel validated in knowing that, you know, we're all on that same page that this is a missing level of care. Okay, so we want to talk a little bit about, you know, sort of how the system is supposed to work. And I'm going to try to move here just a little bit. The afternoon sunshine in my office is wonderful, but it makes me look really weird with the blind lines that kind of run across my face. So I'm going to see if that works a little better. So our physical health care continuum, right? It's really the same as behavioral health, but physical health care seems to be a little bit easier to figure out. So we start with this to kind of show an example and to kind of build upon how these systems are supposed to work. So you start down here on the primary care end, right? And then up from there, you might go to a higher level or outpatient or specialty care. And then at the highest, you know, intensity of services would be inpatient treatment. So, right, the higher the level of complexity, the higher the level of intervention. So primary care means, you know, all those well-child exams, immunizations, and screenings. For children in youth and foster care, that means EPSDT screenings, right, within 30 days of entering care, right? All those kinds of things fall under primary care. Lower risk illnesses, right? Child has colds or flu-like symptoms and needs to go to the doctor. You know, medication management for some conditions and supports for chronic conditions like illnesses or maybe chronic pain. And then outpatient or specialty care would include urgent care, but not the ER, but urgent care or specialists for ongoing monitoring and treatment for certain chronic conditions. So things like allergies, genetic disorders, maybe diabetes, right? Those kinds of things would be some examples of specialty care. And then higher level outpatient, so such specialists such as neurology or endocrinology or ambulatory centers could be a higher level outpatient. And then emergency and inpatient care would be conditions that require an ER visit, like difficulty breathing or chest pain, and then high risk conditions like infections and surgeries, and then rehab for continued therapy once stabilized. So you can see along that continuum what physical health care should look like. So let's see how that plays out for a child who might be in foster care. So Milo is our example here. He's 5 years old and he's been complaining of abdominal discomfort all day and has vomited twice. So caregiver calls the primary care provider to make a same-day appointment, and the urinalysis that was done in that PCP office showed a high level of glucose. Now, we are not medical providers, but since this is a case example, we're going to kind of move along with this, right? We can know that that likely means that Milo might have diabetes, right? Maybe juvenile or type 1 diabetes. So started at the primary care level, right? Had abdominal pain, had a same-day appointment with the primary care provider. But then from there, right, because of the urinalysis, he goes immediately into inpatient care, right? For youth who are suspected of having diabetes, they often will do a 4-day hospital stay for a diabetes workup. So he's going, you know, straight across all those continuums, straight to inpatient care. And then after those 4 days, he's going to move down to a higher level outpatient specialty care, right? Those endocrinology appointments, and probably some other outpatient and specialty care to get some education around how to manage his diabetes for the caregivers, right? And then when he gets back to this place of stabilization and recovery, he's going to continue to have regular appointments with primary care, those regular wellness visits, and then probably going to still need some ongoing support from some specialty care to help manage his diabetes and to remain in that state of stability and recovery. So that's kind of the way the system is supposed to work. And we often find that, you know, maybe it works a little bit smoother for physical healthcare services. Hopefully this doesn't seem, you know, too complicated to anybody. But here's where, whoa, hold on. Maybe you're thinking, oh my gosh, I can't handle this slide on a Friday afternoon, right? This is where things can get a little bit more confusing and a little more complicated. So we're going to talk through how the system is supposed to work for the behavioral health care continuum. And as soon as I kind of walk through this, I'll ask for any volunteers to share, whether or not they've seen the system work this way, or maybe whether or not you have seen the system not work this way. But same sort of idea here. We have primary care on that low level of complexity and low level of intervention. So maybe a youth has some behavioral health care concerns, and they're able to get screened for behavioral health services in their primary care office, or maybe they go to a PCP that uses the collaborative care model or the PCBH model, where behavioral health is actually in-house with the primary care clinic, so they can access some behavioral health clinicians right there with primary care. And then for some youth, they might need to go up from that continuum, right? Maybe they need some community mental health and substance use disorder treatment, so they need some outpatient services, so some ongoing counseling, EBPs, right? Evidence-based practices, things like TFCBT, trauma-focused cognitive behavioral therapy, right? Those kinds of things would fall under specialty care. And then up from there, we get to residential treatment, right? So supportive housing for maybe substance use disorders or sober living. And then up from there could be inpatient treatment. So, maybe youth has some suicidal ideation or has a suicide attempt, and caregiver takes that youth to the ER, right? That would be an example of being inpatient or in the hospital. And then, if it's deemed necessary, right, they might move on to CLIP, the Children's Long-Term Inpatient Program. So we're going to build on that, right, across the spectrum from low to high levels of behavioral health services. There should also be community partners there, right? Peer support, community agencies, housing resources, food resources for families as well. And then crisis services are available no matter where you are on the continuum. So every county or every region, there are 9 regions in Washington. Some counties are their own region, and some regions are made up of multiple counties. But each region has a crisis line that is available for all people who live in that region. And the crisis line can send out the mobile crisis unit with designated crisis responders to help make determinations about, maybe involuntary treatment, that sort of thing. So that hotline is available for everybody. If they've never, ever received behavioral health services before and they're on that low end, but all of a sudden have a crisis, right, they can access it. If it's somebody that's been in specialty care for a while for behavioral health, right, they could access that crisis line as well. And then WISE, right, so Wraparound with Intensive Services exists here in Washington. And that, can kind of work with a youth who maybe is being discharged from the hospital from an inpatient stay, and to help get them back down towards that specialty care. So WISE helps youth with services in the community, and we're going to talk a lot more about accessing WISE in just a minute. But that's kind of where it fits on the continuum, right? WISE kind of straddles a couple of these pieces. And then, right, what we see is there are non-Medicaid behavioral services. So for children and youth in foster care, that means BRS placement, right, and case aids. And so what we also know is there is this missing level of care, right? Placement for youth with intensive behavioral health needs and no medical necessity for residential or inpatient treatment. And so for youth in foster care, right, BRS is kind of the program that tries to address that, to really help provide support to caregivers and families to best to serve those youth. But we know that some of those youth still have a lot of behavioral health challenges, even with BRS supports in place too. So let's take a little case example here to see kind of how this behavioral health continuum might play out. So we've got 12-year-old June. She's admitted to Seattle Children's after a suicide attempt from a medication overdose. So that would be somebody who, started down here on the low end potentially, and then all of a sudden went to that inpatient treatment for 3 days because of that attempt. So she gets a full mental health workup, right? So we're starting here down at inpatient for that 3-day workup. And the discharge plan says, this youth needs a psychiatrist for ongoing medication management, needs a therapist for ongoing behavioral health services, would benefit from peer support as well as an LGBTQ+ support group. And with that, you know, the referral is made to WISE. So at the point of discharge, right, she gets enrolled in WISE and is now receiving higher level outpatient behavioral health services, right? So that's the way we want the system to work. So show of hands or come off mute or use the chat box. Anybody seen the system work really, really well like this? Quiet crowd today. Okay. I'm going to be willing to bet that, you know, there might be cases along the way where it's worked this well, but I'm also going to be willing to bet that many of you are thinking, you know, yeah, right, there are gaps in accessing WISE. It seems like it takes forever to get WISE set up for a youth that I work with, right? So there might be some challenges there. So we're going to talk a little bit more about that too. So graduation from WISE, right? Maybe just receiving some ongoing med management and maybe, you know, continuing with a therapist. So ongoing visits with primary care and behavioral health therapists and psychiatrists would be kind of the services that June would need to access in recovery. So let's think about how this often plays out, right? This is a 12-year-old member still, but rather than, you know, the medication overdose, right? Instead, what happens is June breaks her caregiver's window, and the caregiver is really scared and concerned for her own safety or their own safety, and calls police. So police recommend taking June in to be evaluated at the ER. June is assessed by an ER physician and a behavioral health specialist and does not meet medical necessity criteria for an inpatient stay. She's calm, she's lucid. You know, the ER physician and behavioral health specialist discharge her, and the plan recommendations do include WISE services, but the caregivers has concerns about that June's stability, since WISE services will not begin for 2 weeks, right? So how is this caregiver supposed to, you know, manage June's behaviors for that 2-week period before services can really start? So a couple of things, right? We want to really, really encourage caregivers to call the crisis line if it's a behavioral health concern and not 911, right? Really your first phone call for a crisis would be to call the regional crisis line and not to call 911 for police or law enforcement assistance. So that's kind of the first piece of this here. And then the second piece is kind of what happens during those 2 weeks while we have to wait for WISE. So again, right, every youth has a chance to be happy, healthy, and do well in their community. And the goal is to help people and systems work together to support recovery at every part of the process. So we know at Coordinated Care that systems are complex, and managing these kinds of cases can be really exhausting. So this is where Coordinated Care really comes in. This is really the heart of what Coordinated Care offers to our Apple Health Core Connections members. So the key pieces here are we are here to meet members wherever they are at in their health journey, and services are available even if there isn't a current placement. I can't tell you how many times we hear that. Well, you know, the youth is having hotel stays while awaiting placement, so we can't start WISE. That is absolutely not true. Services are available even if there is not a current placement. And in fact, I would argue services are more important if there isn't a current placement, right? Let's help get this youth stabilized so that they can be successful in a placement, right? Let's use services, behavioral health services, to help that child find some stability. So we can help with issues like delays in WISE services. And again, right, recovery is going to look different for everybody. So before we move on, because that's like kind of a huge chunk here, I keep this on my desk at work, and you know, just being in Zoom meetings all day, sometimes we forget to take care of our body. So while you're thinking about any questions you might want to put in the chat, I would also encourage everybody to take a moment to do some stretches here. I don't think anybody has their camera on, so nobody's gonna see what you look like. And then also, you know, notice some cute puppies and one cute little cat over there doing some yoga poses. We know that looking at cute animal pictures can also boost our mood a little bit. So I'm a dog person, so sorry there's only one cat. All right, okay. Katie says, great to know about help with WISE. Yeah, so I'm gonna dive even deeper about kind of what we do when there's that delay with WISE. All right, so hopefully people are feeling ready to move on and have a little stretch break. All right, so let's figure out kind of what are some of those requirements to access services based on medical necessity, and kind of what coordinated care can do when we know that there is a delay in WISE. Okay. So who decides what services a youth receives, right? Medicaid behavioral health services must be part of the treatment plan, and it's the behavioral health provider, right? The behavioral health provider is the one who determines the services that are needed and the level of care. And they are the one that needs to make referrals for services as clinically indicated. Coordinated care does not prescribe medications, and we cannot refer services, right? Only the youth behavioral health provider can do this. So, you know, if you know of a youth that would benefit from WISE, you can't call us to ask for help enrolling them, right? But you can actually reach out directly to WISE programs in your area. You can reach out to behavioral health providers in your area to help that youth get an appointment, and we can help set up appointments, right? But we can't say, hey, this child needs WISE, right? That is the domain of a licensed behavioral health provider that you know, accepts Medicaid. So WISE, if you're not familiar with it, WISE is a wraparound program. So wraparound is an evidence-based treatment practice that we know is very effective. And WISE is the wraparound program that's used here in Washington State. It came about because of a lawsuit a while back. So WISE is available to help youth live and thrive in their homes and communities. It is for individuals up to age 21 with complex behavioral health needs that could really benefit from a higher level of care or is at risk of an out-of-home placement. So it's also available for those youth who are discharging from CLIP facilities with 30 to 60 days prior to discharge for care coordination and discharge planning. And if you're not familiar with wraparound models, including WISE, utilize a team-based approach to really wrap around the youth and family, right? So providing intensive services to assist them in achieving wellness and safety and to really strengthen communities. So part of that team includes, you know, a licensed therapist. Part of that team includes peer support for the youth. There's generally a family support person as well. So there's just all of these components that are available to help families. In addition, WISE, you know, should have a crisis line too for families to call if there's a kind of an after-hours immediate need or crisis as well. So you can make referrals to WISE, right? You can recommend that a family reach out, and the link is in the PowerPoint to click on there to find out which WISE providers are in each county. And this is a huge change. As of January 1st, 2020, youth who are in BRS can access WISE. So this is something we are still hearing pretty frequently too. Oh, this youth's in BRS, so they can't have WISE. That is not true. That is not true anymore. Youth can receive both BRS and WISE services at the same time. So know that that is absolutely available. And then crisis services must be provided by that youth behavioral health provider or by the WISE team. So if the youth is enrolled in WISE and has, you know, behavioral health services like that, then they should be accessing crisis through their WISE team. So encourage families to call right away to help de-escalate mental health and substance use disorder crises. And then also just know, you know, if you're hearing from families that are saying, you know, my WISE team doesn't provide crisis services, right? That should be a red flag where you say, I went to a training and I think that's not right, and I'm going to reach out to Lindsay, right? Those are the kinds of things you can connect with our team about. If you're hearing any kind of issues with a system that's not working maybe as it's supposed to in your county. So other resources for crisis, right? Every region has that crisis line provided by the BHASO. Those regional crisis lines serve everyone in Washington, regardless of insurance. And you can find the links to those crisis numbers on both the Coordinated Care website as well as the Healthcare Authority website. So both are linked in there. And those are the crisis teams that have the designated crisis responders who can evaluate for the need for voluntary or involuntary hospitalization if somebody's in an acute behavioral health crisis, so meaning mental health or substance use. Okay, So just a little bit on what's covered by Medicaid for substance use disorders. Residential and inpatient substance use is covered, right? So if the person needs secure withdrawal management and stabilization, that is generally urgent and unplanned. So that does not require a prior authorization. The provider just has to notify coordinated care or the managed care plan that the parent has within 24 hours, and then it gets reviewed for medical necessity. If somebody is going into a planned inpatient substance use treatment, if that's a planned admission, then a prior authorization is required. And I think there's actually an error on this. I think they're currently reviewed for medical necessity. I think that might actually be every 7 days instead of every 14 days. Anyway, if you, basically the key point here though is if you're working with a youth who needs some inpatient SUD treatment, make sure you are connecting them with coordinated care. The question you should ask is, hey, have you talked to somebody at coordinated care about this? Because we really want to be there to help support youth and families in getting the treatment that they need. And we know the system's complex. So get us involved, get a care manager on board to help with the prior authorization, to help with all of kind of those processes and procedures. Okay. And then again, as a last resort, after all other community-based services are attempted, CLIP is available here in Washington. So CLIP is an intensive, long-term, inpatient psychiatric treatment course for children ages 5 to 17. So the eligibility criteria includes the primary diagnosis of a severe psychiatric disorder that has determined to significantly impact the child's or youth's ability to function safely and adaptively in a community setting. So they have to have a primary diagnosis of a severe psychiatric disorder. Available community-based mental health resources do not meet the treatment needs of the child or youth. Proper treatment of the psychiatric condition requires services on an inpatient basis. And youth must consent or meet the clinical criteria for an involuntary treatment admission. So kind of some of the key pieces here with CLIP, right? They have to have that primary diagnosis of a severe psychiatric disorder. So they have to, meet some medical necessity here, but then also on top of that, the provider really has to also agree that CLIP will be able to help that youth, right? That it will actually be effective in helping them reach a place of recovery and stability. And so coordinated care staff can assist with resources and information needed for the CLIP referral and application process. So there are only 89 CLIP beds in Washington state, and I don't know the exact current number, but the vast majority of those 89 beds are actually used by Apple Health Core Connections members. So meaning children and youth in the state who are in child welfare, in an out-of-home dependency, or who are in adoption support as well, right? So Apple Health Core Connections members do take up, the majority of the CLIP beds here in Washington. So we have a system of care team, and one of those individuals is actually the CLIP liaison and helps with CLIP packets and, getting everything ready, all those referral packets. So again, if you're ever working on a case where caseworkers are talking about CLIP, you should also ask, hey, have you talked to coordinated care? Have you, gotten the CLIP liaison involved? And if they say no, how would I figure that out, right? You can say, oh, I have some contact information. So we'll kind of go through all that contact info in just a minute here too. Right, so a little bit of what is coordinated care's role with CLIP, right? So we want to, before CLIP, ensure that all community-based behavioral health services have been utilized. We want to help get that youth enrolled in WISE or other community-based services, and ensure that the services they were receiving meet the fidelity of the model, right? Was WISE working the way it was supposed to? Did they have all the components of the wraparound team? And were they providing crisis, right? That's our job to do that. And so we have system of care liaisons, so not just the CLIP liaison, but other system of care liaisons that work very closely with WISE providers across the state too. Facilitating communication between treatment team members, participating in care meetings and placement staffing. And we're going to, advocate for youth to remain at the least restrictive level of care. We want them to be in the least restrictive level of care that is going to meet their needs. But we support and gather information for the CLIP application and can pull that CLIP packet together. And then during and after CLIP, right, once all other resources have been exhausted, we can submit that completed CLIP form. We attend CLIP committee meetings and the monthly CLIP team meetings, helping to prepare for discharge and set up services in the community and ongoing care coordination services so that the youth can be successful outside of CLIP as well. And the CLIP liaison will transition the case to our care management team as part of that discharge process. So along the way, right, that youth is going to have somebody at coordinated care. So either the CLIP liaison as they're in the process or part of our care management team following discharge. So we make sure that there's a warm handoff there and that, you know, as they step down, we're still really, really involved in the case to make sure that the services, that they're getting the services they need and that the services are working for them. Okay. Right, so coordinated care is here to help no matter where the youth is on that continuum of care, right? Finding a PCP, we can do that. Scheduling appointments, right? We know sometimes it can be really difficult to find a dentist or find a specialty care provider. So you can encourage families to call us and we can do a lot of that legwork for families. If they need help accessing medical records or finding culturally appropriate PCPs. We have definitely received calls from members saying, you know, I've had this negative experience with a provider that, you know, was not affirming of my gender identity or sexual orientation, and I really need a PCP who, you know, will call me by my preferred pronouns. We can help them find a provider that's going to be a good fit that way as well. Outpatient or specialty care, right? Finding culturally appropriate specialty providers. We can help communicate with doctors, pharmacies, medical equipment suppliers when there's any kind of issues or things that just aren't working quite right. Coordination of referrals as well, right? So if the youth is getting referred on for surgery, something I was working on just a couple of weeks ago for a youth, right? We can help with that and make sure it was a, you know, provider that said, oh, I need to have the physical ID card, and the caregiver didn't have the physical ID card, right? We can help navigate all those kinds of little hiccups that come up in the system. And then a good thing to know too is, you know, anytime one of our members through Apple Health Core Connections goes into the ED, we receive a report of that on a daily basis. And so for those members, we're doing outreach to help make sure they're getting connected to the services that are recommended in discharge. And part of that is also, you know, helping with screening for suicide and depression, and really making sure that our members are getting access to the services that they need, kind of ongoing for any kind of suicidal ideation or depression as well. And then inpatient care, right? Planning for discharge, CLIP packet creation, ensuring foster parents and families have resources needed for that child to come home, and facilitating communication between hospitals and other providers. So really, wherever that child or youth is across that continuum, hey, I need help finding a provider, to, hey, we need help with the CLIP packet. Coordinated care is there every step of the way. So how, right? How do you reach out? The first step, you can give families kind of two options that you might be working with. Families can call us, that 844-354-9876 number, and then they press 2 for member services. Our contract with the state says that our average wait time cannot exceed, I think, 30 seconds, and I don't know exactly where we are now, but I know last year it was something around 19 seconds or so was kind of the average wait time to speak to a real live person. But that person's probably going to be in the call center, and they can do some things, but they can't do everything. And so for our Apple Health Core Connections members, we strongly, strongly encourage them to say the phrase, I need healthcare coordination. So if they're calling and the call center says, oh, I can help with, you know, an address change, or I can help you find a provider, it's our care coordination team that can really kind of do that deeper digging and help make sure that it gets, you know, to a provider that's going to be really the right fit for that child. So a good phrase is to say, yeah, I hear that, but I think I need some extra help. I really need healthcare coordination. And that should trigger them to transfer you over to the right care coordination team. Or if you don't want to do that process, family doesn't want to call, wants to maybe schedule a time to talk to somebody because we're all so busy and have all these back-to-back Zooms and online schooling and everything else, families can send us an email. Or really anybody could send us an email. You could send us an email and say, hey, this is the member's name and this is their date of birth, and I know this family is having a really hard time scheduling a surgery, or this family is having a hard time accessing WISE services, or whatever it might be. And unless we have, permission and a release of information on file, we're not going to be able to respond back to you. But if we receive that email from you, we will reach out to the family. We won't be able to confirm that we've done that with you unless there's, a release of information on file. So you could submit a request through that care coordination email box, or encourage caregivers to reach out to us through that email box as well. And the key phrase again is healthcare coordination. Okay. So I want to pause there for more questions. That's really kind of the meat and potatoes. So what questions came up for you that maybe I did not answer about sort of kind of what coordinated care can do for families, or maybe even some examples of, hey, this is what happened. What should I have done, right? What would have made this kind of go better, or what could coordinated care have done for me in that moment? Or just any other questions around navigating physical and behavioral health care systems.
Hi, Lindsay.
Hi.
Hi, this is Ann McAvoy with Grace Harbor County. And so I heard you say, I just want to reiterate because I'm excited about this, that starting in January of 2021, they can still receive WISE services and BRS services at the same time, or correct?
Yeah, actually it started January 1st, 2020. They can already receive both at the same time.
Oh, so this is already starting. Okay, so when we run into that obstacle of saying they can't receive both, then we can't contact coordinated care. Is that correct?
Yep, absolutely. You can send, and whoops, I'm going the wrong way here. You can send an email to that main email box, or again, that sounds like it might be a little bit more of a complicated issue. So Grace Harbor is out on the peninsula, is that correct?
Yes, it is.
I think that's right. Yeah. So the right contact person would probably be Jen Estroff. She is our healthcare liaison for that region, and you'll see her contact information in a couple more slides. And Jen Estroff would be all over that and working with the WISE providers and the BRS teams and DCYF to make sure that that youth gets all the services that they need. So if you're hearing, no, they can't have both, I would ping Jen.
Thank you very much, Lindsay. I appreciate that clarification.
Yeah, absolutely. Anything else I can answer for people? All right, we'll keep on going here then. All right. Taking a look at some terms that are commonly used differently by child welfare and healthcare systems. So the biggest one we see is probably placement, right? This is not a huge surprise. Child welfare uses the term placement to describe, where the child is approved to stay and sleep by DCYF, right? Do they have a placement? In healthcare, right, when we hear placement, we are thinking a bed in an inpatient facility. And so, this can kind of cause some confusion sometimes, right? And understanding that distinction, right? The child may not meet medical necessity for an inpatient facility, but that doesn't mean that their behaviors aren't causing a lot of challenges in getting an approved placement with DCYF, right? A family that can really meet that child's unique or kind of challenging symptoms and behaviors. And then stable. In child welfare, that's often referring to that child's ability to function at home, schools, or socially with guidance. And stable in healthcare really means that there's no acute medical need, right? The healthcare needs overall are well managed. And then crisis in child welfare is typically referred to, things like frequent running from care or unable to find a suitable placement, right? No placements are able to manage this child's behaviors, this child's in crisis, right? And then in healthcare, crisis they could be having a crisis on both sides, right? But for healthcare, crisis is very specific to, extreme emotional disturbances where that youth or child may be considering harm to self or others, disoriented or out of touch with reality, and has a compromised ability to function, or is otherwise agitated and unable to be calmed, right? And that's really when we want to be using those crisis services, either through the WISE team, or if they don't have a WISE team, using the regional crisis line, but not calling 911. And then medical necessity, I'm not going to read all this to you, kind of have it as a resource later. But medical necessity, really, when we're using that phrase, we are telling you what's covered by Medicaid based on the youth's medical and behavioral diagnosis, right? So what is covered, and that's really the key to all Medicaid services here in Washington, right? It has to meet this level of medical necessity in order for a child to access a particular service. And then behavioral health in the healthcare world, right? We're really talking about the clinical diagnosis of a medical condition, and then the symptoms of which are the behaviors that you see, whereas child welfare will often use behavioral health as a term to kind of describe all of the challenging behaviors that might be exhibited, right? Explosive anger, or hair pulling, poop smearing, running away, cutting, hoarding food, yelling, those kinds of things may be kind of how child welfare is using the term behavioral health. So if it's not clear how we are using a term, please ask, right? We want to be on the same page with everybody. And so this is definitely, I think those two slides are probably most important for DCYF staff, right? But sometimes we're not always on the same page with what we mean by phrases. Okay, so I want to just kind of give a broader view of sort of what's covered by Medicaid here in Washington. And so what services are available for our members. So this list, right, is for everybody who has Medicaid. The benefits are set by healthcare authority, but you know, obviously that applies to our Apple Health Care Connections members, so they can have access to doctor office visits, urgent care, ER visits if they need it, vision exams. So for youth 20 and younger, they can get a vision exam once a year. And then for youth 21 and up, it's a vision exam every other year. So if you happen to work with any youth who are getting close to 21, really encouraging them to, you know, make sure they're utilizing those vision benefits before the benefit kind of goes down a little bit. Prescriptions are covered. Because of COVID-19, we've actually increased the number of prescriptions that are available to be received to the doorstep. So families don't have to go to a pharmacy to pick up a prescription. They can get certain medications delivered through home scripts. And if anybody has questions on that, I can provide some more information. Hearing aids, hearing exams, durable medical equipment. If a family is having a hard time with DME, that's one that comes up a lot. Just give us a call or send us an email, right? That's something we want to be involved in to help make sure they get the DME that they need. Hospital care, home health, physical therapy, specialty therapies like speech and OT, right? Those are covered by Medicaid, assuming medical necessity. Transplants, lab tests, x-rays. Family planning is also covered. So contraceptive is covered at no cost. And youth can access, or Medicaid members can access contraception, over-the-counter contraception without a prescription. So youth can actually get condoms at the pharmacy as long as that pharmacy is in network with coordinated care. And they don't even need a prescription from their provider. They can just show their Medicaid card to get those. And also for Plan B on the family planning. Disease management, right? So we have some programs specifically designed to help caregivers who are caring for a child with a chronic health condition like asthma or diabetes, helping getting them set up with some education and some coaching on how to manage those conditions. Transgender benefits are also covered by Medicaid here in Washington. So both hormone blockers, hormone replacement treatments, and surgical services are all covered by Medicaid. You know, there are some processes, some hoops to kind of jump through to access all of those services. And then, as we've been talking a lot about today, behavioral health, outpatient and inpatient, and drug and alcohol treatments are all covered benefits by Medicaid as well. So just to kind of, again, reiterate, I think a lot of this we've talked about today, but we want to just be very clear about, you know, what is covered by coordinated care versus what is not covered by coordinated care. So in the outpatient world there, right, mental health medications, non-emergency medical transportation. Ooh, we haven't talked about that yet. So here in Washington, Medicaid actually does cover transportation to appointments. They're going to use the sort of most cost-effective means. So for some counties, that might look like bus tickets or maybe ferry passes. but for some communities, that might actually be an actual ride, right? So non-emergency medical transportation, you can't call the regional broker and say, hey, I am having a crisis and I need help getting to the ER, right? They can't help with that. But if you have for ongoing counseling appointments or something like that, a family can use that non-emergency medical transportation, and I can send out the link to find out who the broker is for your county. Individual, group, and family counseling services are all covered by Medicaid. Many evidence-based practices are also covered, right? Sometimes DCYF has contracts with providers to do EBPs for families that are in dependency. And so they, might have access to things like Triple P or CPP through DCYF and also through Medicaid. Urgent care, psychological assessments, neuropsych testing, if it meets medical necessity. I think this is something we see in the court sometimes, right? Court orders that say, we need a neuropsych evaluation done and it needs to be done within 30 days. Well, if there's, no provider who can do a neuropsych within the next month, right? Definitely call us and get us involved. But again, if it doesn't meet medical necessity, it might be, DCYF paying for that out of pocket, or it might be, something where we have to get on a wait list with a provider for a while before that can happen if the person does meet medical necessity for that neuropsych eval. So definitely reach out. That's another great time to reach out to us. Right, screening for drug and alcohol use disorders, rehabilitation and case management, that's all covered at the outpatient level. I'm trying to think if there's anything else. ABA, applied behavior analysis, right? So that youth would need to receive a diagnosis from an Autism Center of Excellence in order to receive those ABA services. And sometimes there can be a wait list there too. So again, you can call us. Occasionally we do have success kind of getting youth in for appointments a little bit quicker, or can kind of help get on multiple wait lists and those kinds of things for youth as well. Yeah, the inpatient, right, there's the clip, withdrawal management, inpatient psychiatric evaluations and treatment, and then crisis, if they go to the ER or that mobile outreach crisis team from the regional lines, that's all covered. What's not covered, right, so gray column kind of over on the side, case aids, respite care, right, maybe it's a foster home that's been having a lot of challenging behaviors and kind of needs a break, right? Medicaid cannot pay for respite care. We cannot pay for placement or housing. We do not cover BRS services, and we don't cover transportation that's not related to medical appointments. So for example, we could not cover transportation to visitation with a parent. Okay. One other kind of key piece I want to just highlight here, starting in February of 2020, so the timing actually ended up being really good, but starting in February of this year, we launched a partnership with Teladoc. So Teladoc is a telehealth provider here in Washington, and they have many doctors and providers that are in their network that are all based locally here in Washington, and they are available 24 hours for non-emergency issues. So families can set up an account via the mobile app. So they can go to the App Store and download a free app that's called Teladoc, or they can access it from the web. It takes literally max 2 minutes to set up an account. Just really need that name and that date of birth, and can set up an account for a member. And then from there can schedule appointments for things like colds or flu-like symptoms or fevers, sinus problems, allergies, upper respiratory infections, bronchitis, maybe you want help or coaching around smoking cessation, and that includes vaping, not just cigarettes, or maybe they have rash or skin conditions and need a dermatology appointment. There's actually dermatologists that are a part of that Teladoc program as well. And then for people who are over the age of 18, so only over 18, they can actually access behavioral health services via Teladoc. And if they connect with a counselor they really like in Teladoc, they can actually set up ongoing appointments with that specific provider. So really great resource, again, if, families are trying to limit exposure outside of the home, or maybe, they can't get a same-day appointment at their primary care provider for cold or flu-like symptoms. Teledoc is another really wonderful resource for families. So I will send out the Teledoc flyer as well, and feel free to share far and wide. And we really encourage all of our members to go ahead and set up an account, and then they've got it in case they need it. So you should never really ever need to know this, but the Provider One card also exists. So that's the teal Provider One card. If you've been in this field for a while, you probably remember it. Before coordinated care, before the Coordinated Care Apple Health Core Connections program went live in April of 2016, youth in foster care just had this teal Provider One service card. They didn't have coordinated care. All they had was this teal Provider One card, and they used it for all of their Medicaid services. And there's actually a few things that they still use the Provider One card for, but that Provider One number is on the Coordinated Care ID card, and no family should ever really have to know what's getting billed through Provider One and what's getting billed through Coordinated Care, right? We never want people to have to be that in the weeds about it, but just sort of so you know, right, this card might be what Native youth who are not enrolled in Apple Health Core Connections have, right? And so they're using it for all their Medicaid services. And then for other youth that have coordinated care, right, they're also going to have this Teal Provider One card, and that's actually what covers dental services and eyeglasses, right? So for kids that need glasses, it's actually Provider One that covers the vision hardware. And so glasses are only available to Medicaid members in Washington that are 20 and younger. So once they turn 21, Medicaid no longer covers glasses. So if you're working with a youth who's getting close to 21, really highly encourage them, if they're eligible for a new pair of glasses, to go do that before that benefit goes away. Sometimes people ask me about, what about contacts, right? I've got a youth that plays sports and really wants contacts. Contacts are only covered if it meets medical necessity. So there are certain prescriptions that are high enough, or you know, certain prescriptions that you know, a youth might meet that medical necessity for contacts. But if they don't meet that medical necessity, then it's only glasses that are available. Yeah. Again, non-Medicaid services, VRS placements, therapeutic foster homes, case aids, that's paid for by DCYF. DDA services, Developmental Disabilities Administration. IEPs, I will say though, you know, for those of our youth that have complex care needs, our care managers often will participate telephonically with IEP meetings to really help make sure that the youth's complex care needs are, you know, addressed appropriately in the IEP as well. So we can provide some support around IEPs, but that is, you know, not a Medicaid service, right? That's something through the school district. Respite care, and again, transportation that is not to medical appointments or due to a medical emergency. So if there's a need for any of these services for a youth, right, we can collaborate to ensure that it's part of the system of care. And we, you know, frequently do a lot of work on helping get kids connected and supported by this, right? Getting kids connected to DDA if they need it, kind of working with DCYF and the whole team to make sure they get connected to all the services that they're eligible for. So again, there's the WISE referral or contact list, and the mental health crisis lines are in there once again. And again, here's the main line to reach our care coordination team, and that email address. And really, I just want to open it up for questions. I think that's been my experience with this training is people have a lot of questions. So, you know, there's no bad questions. Feel free to ask me anything. While you're formulating your questions, I'll just show you the last couple of slides here so you can see. So Anne, when I was telling you, you know, if you're having an issue with BRS and WISE at the same time, Jen Estroff, she's got your back. She covers regions 5 and 6 and can help troubleshoot those kinds of issues.
Great, thank you.
And there's me. I'm Lindsay. There's my cell phone number. You can call or text me or send me an email. Like I said, I think some of you that have been doing some of these trainings that Ryan has set up might be familiar with Zia. She's sort of the Eastern Central Washington version of me. So like Zia, my main role is actually to offer training around trauma-informed care and resilience and ACEs and secondary trauma and self-care. But again, we can do these kinds of Medicaid overviews and kind of this deeper dive into how we actually access services. So if you're a part of any other organizations or maybe court systems or other places that you think would benefit from some of our trainings, either Medicaid or the clinical trainings, feel free to reach out to either me or Heather or Zia, and we would love to coordinate with you on that.